Proptosis is a forward movement of the globe in relation to the skull, which is measured by protrusion of the apex of the cornea in front of the outer orbital rim. And an abnormal finding would be something greater than 21 millimeter or a difference of greater than 2 millimeter between the two eyes. The axial proptosis when the eye is displaced. Sorry. Axial proptosis is one when the eye is displaced straight outward along the anteroposterior orbital axis, especially found in kind of a thyroid ophthalmopathy or an intracorneal lesion like this where you have an axial proptosis. Abaxial proptosis is when the eye is pushed forward and also displaced off the central axis, whether inferiorly or a lateral displacement, especially found in extracorneal tumors like this was a lacrimal gland tumor where you can see the inferior displacement. And sometimes you can get an apparent proptosis conditions like unilateral high myopia or a craniosynostosis, or this is a case of a right eye inferior blowout fracture where you can see the left eye apparently seems to be proptotic. In clinical workup, age, the duration of the illness, the onset, whether it's an acute or a long-term proptosis, the progression, and look for the associations carefully, especially vision loss, diplopia, any pain, any swelling, which can give a hint about the diagnosis. Systemic illness has to be ruled out, and the past history, especially thyroid trauma or either any other malignancy in the body, has to be ruled out. Now, coming on to the inspection, we'll go each point one by one. Facial symmetry has to be looked carefully. If you look carefully, there is a slight periorbital fullness over here, which is corresponding to the lateral dermoid in this case. Again, to note whether it's an axial proptosis like in this patient with a thyroid ophthalmopathy versus an abaxial proptosis with a superior orbital lesion, which turn out to be a lacrimal gland tumor again. Periorbital fullness again like in this case, and in this case, which turn out to be a hemangiopericystoma. Skin changes has to be looked carefully. If you can see the bluish hinge of the conjunctiva or skin around, which can be indicative of a vascular malformation, and in xanthogranuloma you get this bogginess and sometimes yellowish pigmentation. Palpebral aperture changes has to be noted carefully. Lid retraction, which is an hallmark of a thyroid ophthalmopathy with a lateral flare. Then position of the globe you can judge by either a Nafziger's view, which is a typically taught view for us, or a worm's eye view where you can see this is a patient with a left eye proptosis. Now coming on to the exophthalmometry, as we all know, it measures in an anteroposterior plane the distance between the apex of the cornea and a bony point usually taken to the deepest portion of the lateral orbital margin with the eye looking straight ahead. That is very important. It could be of three types. Absolute, when we are comparing with a normal reading and we say if it is more than 21 millimeter, probably it's a proptosis. Relative, when you are comparing between the two eyes, a difference of 2 millimeter would give an indication. And a comparative, where we are comparing with the previous finding, something we do in cases of thyroid ophthalmopathy to look for the activity. Commonly used instruments would be Hertel's exophthalmometer, and the lateral or inferior displacement is better checked with the transparent two rulers. Lude's exophthalmometer, which has a notch which confirms the angle of the lateral orbital rim. Now, in palpation as such, or in inspection as such, we can see the tumor surface, whether there are any prominent vessels or has this nodular ill-defiled kind of a lesion. This was a recurrent pleomorphic adenoma. You should also look for an ulceration or destruction of the surrounding structure, which gives more in favor of malignancy or a necrotizing lesion. Again, look for the conjunctival or phonical, by looking up the phonesis carefully. Like in this case, there was this vascular malformation. Here you can see slight corkscrewing of the vessel. Here you can see this salmon patch kind of appearance, and here it was a diffuse lesion with a frozen globe kind of a picture. Valsalva is very important, especially to rule out vascular malformation. As you can see in this case, patient has slight fullness of the left eye. Sorry for the poor contrast over there. And you can see when we ask the patient to bend for around 30 seconds, you can see the fullness around here, which is an indicative of probably a vascular malformation, something like a varices. In few of the patient, this is a young patient with a left eye chewing induced oscillopsia. It's not starting or not. Okay, I'll show this video afterwards. Here, the patient had a chewing induced oscillopsia. There was a dermoid which was connected with the angle of the jaw, and on chewing he had this proptosis. Also look for any visible pulsation, and ocular examination, complete ocular examination including anterior and posterior segment has to be done, along with look for carefully optociliary shunts to differentiate between whether it's a meningioma or a glioma. In palpation, we always start with the orbital rim. We relax the orbital septa, ask the patient to look in a down gaze sometimes if the lesion is superiorly. Look for the location, extent, border, and fixity of the bone is very important. Fixity of the bone could give an indication that probably it's a malignant lesion. Look for tenderness, surface, temperature. Now, temperature is very important, especially in cases of inflammatory or infective lesion, you would have a higher temperature. And in cases of benign lesion, probably there will not be any rise in the temperature. Consistency of the lesion surrounding bone structures. Retropulsion test has to be done to rule out, whether it's an intraconal lesion or not. Pulsation of the tumor, as you can see in cases of AV malformation, or sometimes when there is transmitted pulsation, especially seen in cases with neurofibromatosis. Systemic examination has to be done carefully, like this was a patient with plexiform neurofibroma. You can get capsular spots in few of the patients. Bilateral proptosis is commonly seen in cases of thyroid eye disease, that is the most common cause in adult. Lymphoproliferative disease and cavernous sinus thrombosis can lead to a bilateral proptosis. In children, especially acute leukemias, sometimes neuroblastoma or a pseudotumor can have this kind of a picture. Axial proptosis, the common condition would be thyroid ophthalmopathy, meningioma, optic nerve, glioma, or cavernous imago. These are the 4 common conditions which will come with an axial proptosis. And a non-axial proptosis in an adult would be something like a lacrimal gland tumor, schwannoma, dermoids, mucosal, or lymphoma. This is what we commonly get in a clinical practice. Sometimes, as per the age also, you can probably say what kind of a lesion it could be. Now, I'll just briefly highlight few of the lesion and what is the important finding in them to look forward. This is a typical case of encephalocele or a meningocele. Teratoma are common in children, where both all the 3 ectodermal, mesodermal, and endodermal elements will be there. On a CT scan, you can see something like this, which is an indicative of an ectodermal element. Lymphangioma are a benign congenital vascular malformation, and they generally present with a sudden proptosis, which occurs from the hemorrhage into cyst, which is typically called as a chocolate cyst. On USG, you can see this, dancing. Sorry. On USG, you can see, these dancing spike. Sorry. You can see this dancing spike kind of a picture, and you can see this fluid-filled spaces in between, indicative of a lymphangioma. Again, on conjunctival pharyngeal examination, you can see this vascular bluish hinge. In the children, especially within first decade, if you are having a rapid unilateral proptosis with globe displacement, always go ahead with either a MRI or a CT scan, which shows an irregular margins, and if there is a bony destruction, there should be a strong suspicion of rhabdomyosarcoma. In children, you do get leukemia and granulomatic sarcoma. Leukemia are unilaterally generally more common, and the soft tissue infiltration will be seen in most of them. Recurrent pleomorphic adenoma will have this nodular kind of an appearance in few of the cases, as you can see on the CT scan also. Adenoid cystic carcinoma is has a rapid proptosis with of less than 1 year duration, and will present with a pain or paresthesia, especially because of bony infiltration or a perineural invasion, and extension toward the apex of the orbit or in the brain is the likelihood. That's why we need to intervene as early as possible. Cavernous hemangioma is again one of the common encapsulated lesions, which are well defined kind of a lesion. Yeah.
The time is almost up.
Yeah, ma'am. This is a few of the last slide, and always look for the secondary orbital tumors and metastatic tumors in few of the cases. That's it. Yeah. Thank you. Thanks a lot.